If a doctor has ever looked at your blood pressure reading and told you to cut back on salt, put away the crisps, and stop reaching for the shaker at dinner, you're far from alone. That's usually the first and sometimes the only piece of advice people get. Maybe you walked out with a pamphlet. Maybe you were told to come back in half a year and see how things look. And to be fair, that advice isn't wrong exactly. Sodium does play a role. But the problem is that it dominates the entire conversation so completely that everything else gets pushed aside, and that narrow focus has quietly failed millions of people who are doing everything they were told and still watching their numbers refuse to budge. I spent close to a decade working in emergency departments, and I've lost count of how many patients came through those doors with blood pressure that simply wouldn't come down, no matter how many tablets we added or how carefully they avoided salty snacks. And what struck me every time was the assumption baked into the whole system. If the numbers aren't improving, the patient must be doing something wrong. They must be cheating on their diet, forgetting doses, not being honest with us. That assumption is usually false, and it's done real damage to how people understand their own bodies. My name is Dr. Wilson, and these days my focus has shifted away from managing emergencies after the fact and toward understanding why people end up in that emergency bay in the first place. Blood pressure turns out to be one of the clearest windows into that question, because nearly every chronic disease we deal with eventually shows up in the state of someone's blood vessels. So let's actually build the full picture here, because there's a lot of ground to cover. We'll start with what those two numbers on the cuff actually represent, then move into the three physiological systems that govern blood pressure moment to moment. From there, we'll talk honestly about sodium, giving it the nuance it deserves rather than either dismissing it or treating it as the whole story. Then we'll get into the piece almost nobody brings up in a routine appointment: insulin. In my view, chronically elevated insulin is the single most underappreciated driver of high blood pressure in modern life. And once you understand the three separate ways it operates, you won't be able to look at a dinner plate the same way again. After that, we'll cover ultra-processed food as a whole package rather than just a delivery vehicle for salt. And then we'll get practical: exercise, sleep, potassium, and meal timing, with the actual mechanism behind each one rather than vague reassurances that they're good for you. Blood pressure, at its simplest, is the force your circulating blood exerts against artery walls as your heart pushes it through your body. The top number, systolic pressure, reflects the surge as your heart contracts. The bottom number, diastolic pressure, reflects what's happening in the quieter moment between beats as your heart refills. Diastolic pressure gets far less attention than it deserves, particularly in younger adults, where elevated diastolic readings alone are more common than most people assume. Under 120/80 is generally considered normal. Consistently above 130/80 typically earns the label of hypertension, though exact cutoffs vary by country and guideline. Numbers climbing above 180 are what bring people into emergency rooms with headaches, blurred vision, or occasionally something far more serious. But the overwhelming majority of people with high blood pressure sit in a much quieter middle zone, not dramatic on any single day, but corrosive over years. That's really the operative word: corrosive. High blood pressure rarely announces itself. It works quietly on the small vessels feeding your kidneys, the arteries supplying your heart muscle, the delicate vasculature in your eyes and brain, even circulation in less discussed areas like erectile tissue. It accelerates the stiffening and aging of your arteries, making them more prone to plaque buildup and clotting, the underlying mechanics behind heart attacks and strokes. And here's something worth remembering before we go further. Blood pressure isn't a static number traceable to one bad decision. It fluctuates constantly throughout the day, rising with stress or activity and dropping during sleep. It shifts with posture, breathing, and hydration. Many people experience what's called white coat elevation, where readings spike in a clinical setting purely from anxiety but sit normally everywhere else, which is why home monitoring often paints a more honest picture than a single office visit. Underneath every reading sits a negotiation between three interacting systems. There's blood volume, meaning how much fluid is circulating. There's vascular resistance, meaning how constricted or relaxed your blood vessels are. And there's cardiac output, meaning how forcefully and rapidly your heart is working. Shift any one of these and your pressure changes, but each is itself governed by hormonal and neurological signals. So the real question is never which of the three is off. It's what's driving the miscalibration in the first place. The first regulatory system is your kidneys, which continuously filter blood and decide, moment to moment, what stays and what gets excreted. More retained fluid means more volume pressing on vessel walls, meaning higher pressure. When pressure drops too low, your kidneys release an enzyme that triggers a hormonal chain reaction, eventually producing a compound that constricts blood vessels directly and signals your adrenal glands to release a hormone that tells your kidneys to hold on to sodium, and water follows sodium. This entire cascade is the reason certain blood pressure medications work by interrupting it at different points. The second system involves your blood vessels themselves, particularly the single layer of cells lining every vessel called the endothelium. Far from being passive tubing, this tissue actively senses blood flow and produces nitric oxide, a short-lived signaling gas that relaxes surrounding muscle and widens the vessel, lowering resistance. When the endothelium is damaged by inflammation, oxidative stress, or chronically elevated blood sugar and insulin, nitric oxide production drops, vessels stiffen, and pressure climbs. This kind of damage accumulates over years rather than reversing overnight, which is part of why long-standing hypertension becomes progressively harder to treat. The third system is your autonomic nervous system, specifically its sympathetic branch, responsible for the fight-or-flight response that speeds your heart rate and narrows your vessels. That's entirely appropriate during genuine emergencies. The trouble starts when that branch never fully powers down, when even at rest your nervous system keeps quietly pushing your heart to work harder and your vessels to stay narrowed. This is precisely why chronic stress, poor sleep, and constant caffeine intake correlate so strongly with elevated readings. Now, about sodium specifically, since it deserves honesty rather than dismissal. Sodium pulls water toward it, so when its concentration rises, your body retains more fluid to dilute it, raising blood volume and pressure. Major dietary trials have shown real, measurable blood pressure reductions from sodium restriction in certain populations. But salt sensitivity, meaning how strongly an individual's pressure responds to sodium intake, varies enormously between people. Those with kidney disease are highly sensitive because their kidneys have lost some capacity to excrete excess sodium efficiently. Older adults tend to be more sensitive too, as kidney function naturally declines with age. Documented ethnic differences also exist, with certain populations showing higher average sensitivity, likely tied to evolutionary adaptations. But in a large proportion of hypertensive people, especially younger adults with healthy kidneys, sodium sensitivity is modest at best, and the relationship between sodium intake and cardiovascular risk may actually be closer to a J-shaped curve than a straight line, meaning extremely low intake isn't automatically ideal either. So if salt reduction alone isn't closing the gap for most people, what is? The answer, more often than clinicians acknowledge, is chronically elevated insulin. Insulin's textbook job is managing blood sugar, but it has receptors throughout the kidneys, blood vessels, and nervous system, and when it stays elevated persistently rather than rising and falling appropriately around meals, three separate mechanisms kick in simultaneously. First, insulin acts directly on kidney tubules to promote sodium retention, independent of the hormonal cascade mentioned earlier. There's an evolutionary logic buried in this. In ancestral conditions, eating and physical exertion happen together, making some sodium retention useful. Today, we maintain elevated insulin for hours without matching physical demand, so the retention signal runs constantly. Second, elevated insulin directly stimulates the sympathetic nervous system, and this has been demonstrated experimentally. Infusing insulin into a person's bloodstream measurably increases sympathetic nerve activity within minutes. Third, chronically high insulin and the elevated blood sugar that typically accompanies it generate oxidative stress in vessel walls, essentially a form of biochemical rusting that damages the endothelium and suppresses nitric oxide production. put together, one hormone, three simultaneous pressure-raising pathways. And what drives chronic insulin elevation across modern populations is largely dietary pattern, specifically frequent consumption of rapidly digested refined carbohydrates and near-constant grazing throughout the day, which never allows insulin to return to a true baseline between meals. I think of a patient I once treated, a woman in her late 50s whom I'll call Margaret, who had been placed on 3 separate blood pressure medications over 4 years despite scrupulously avoiding salt. When we mapped out her eating pattern, she was consuming small carbohydrate-heavy snacks roughly every 90 minutes from 7 in the morning until nearly 11 at night. Her insulin was almost never given the chance to settle. We didn't overhaul her diet dramatically. We simply compressed her eating window and cut the late evening snacking. Within 10 weeks, her readings had dropped enough that her physician reduced one of her medications. This is also why ultra-processed foods matter so much, not merely as salt carriers, but as a coordinated assault on the whole system. They deliver rapidly absorbed, refined carbohydrates that spike glucose and demand a large insulin response. They're typically loaded with sodium at the exact moment insulin is telling kidneys to retain it, and they're almost universally stripped of potassium, since food processing destroys the plant cell structures where potassium naturally resides. Potassium functions as sodium's physiological counterbalance in the kidney. More potassium promotes more sodium excretion and helps relax vascular smooth muscle directly. Population-level trials have shown that increasing dietary potassium can meaningfully lower systolic blood pressure, and the benefit doesn't require supplements, just a return to whole plant foods like legumes, leafy greens, and fruit. Exercise deserves specific mention because its blood pressure benefit isn't just generic wellness advice. Physical activity is one of the most potent stimulators of nitric oxide production, since increased blood flow creates shear stress that endothelial cells sense and respond to by ramping up the enzyme responsible for making that relaxing gas. This effect persists even in people who don't lose significant weight, meaning the pathway is vascular, not purely metabolic. Resistance training carries comparable evidence to aerobic activity now, and moderate intensity movement spread across most days of the week captures the majority of the benefit. More isn't dramatically better from a blood pressure standpoint specifically. Sleep is the piece most commonly overlooked. During deep sleep, sympathetic nervous system activity drops substantially, allowing blood pressure to fall by 10 to 20% overnight, a healthy pattern called the nocturnal dip. People with fragmented sleep, sleep apnea, or chronic short sleep duration often show a blunted or absent dip, meaning their cardiovascular system never gets its nightly rest. Sleep apnea in particular is frequently overlooked as a cause of stubborn, treatment-resistant hypertension, and addressing it can sometimes allow medication doses to come down substantially. None of this diminishes the role of medication, which remains essential and life-saving, particularly at severely elevated readings where waiting on lifestyle change simply isn't safe. But medications interrupt the downstream cascade without necessarily resolving what triggered it in the first place, which is part of why dosages tend to climb over time in people who don't address the underlying drivers. Understanding the full mechanism, why the food environment works against physiology, why fatigue and cravings between meals connect to the same hormonal thread as the number on the cuff, tends to make lifestyle changes feel purposeful rather than arbitrary, and that sense of purpose is often what makes them sustainable.